Thank you so much, sir. Both of you. Thank you so much for joining us. So, as the topic is on revolutionizing healthcare with groundbreaking government digital initiatives, we have the perfect audience for this discussion today. And let us start with our first question. Mr. Himanshu, sir, can you please get us a brief rundown of the overview of the evolutionary journey in terms of digital health focused government initiatives in India? And also, if you could go into detail the initiatives that are currently being focused in this year or the last year, so that the audience present here can leverage from it and also support the government in some way. Over to you.
Thank you. Good morning to all present here. I think it's a wonderful way to begin the session and the conversation which we are having right now. So, to give a brief overview of what has happened till now in the realm of digital technology, I'll start from 2017 when the National Health Policy came out. So, National Health Policy, you would see there is a mention of the digital word at least 10 to 15 times in the entire document. But specifically, the point number 23 mentions about creating a national digital health tech ecosystem, and that has become the word through which government has taken subsequent steps. In 2018, the National Health Stack document came out by Niti Aayog, which then guided the National Digital Health Blueprint in 2019, which then eventually culminated into National Digital Health Mission, which was launched in 2020 by the Honorable Prime Minister from the ramparts of Red Fort. It started with pilot in 6 union territories, and in the subsequent year, you can say the pandemic year in 2021, September 2021, the NDHM was renamed as Ayushman Bharat Digital Mission, and it was rolled out across country. So it has recently completed, you can say, more than 2.5 years in making. And I'll give you a brief two examples why digital health has become a key word or key buzzword, and particularly these sprung out from the pandemic times, where two of the critical examples which you also alluded to in your opening remarks about the teleconsultation. So e-Sanjeevani has become one of the most used teleconsultation solution in the country, clogging around 4 lakh consultation per day, and so far it has done 20 crore consultations. So you can see the scale with which it is working. And the second is, of course, with which every one of has touched upon, is the COVID, which has done more than 200 crore vaccine doses to the 100 crore population of ours. And on one fine particular day, on 17 September, we clocked 2.5 crore vaccine doses, which is, you can say, more than population of 175 countries in the world, which we did in one day. So there has been a lot of going on in the realm of digital, but particularly after the nationwide launch of ABDM, you can say we have made a huge leap forward in creating the national digital health ecosystem. And to give you a brief overview, what we are doing in digital health mission is that we are creating interoperability in the healthcare. Now, interoperability of health data, interoperability of claims, interoperability of health services. And this we are doing with the help of the buzzword which you might have heard during the G20, the digital public infrastructure. So we are making at the National Health Authority the digital public infrastructure for the healthcare. And under this, we are making a consent manager, we are making a unified health interface, which would be equivalent of UPI, but 100 times bigger than the UPI. And the last is the National Health Claims Exchange, which you might have heard recently from IRDI that all the claims in the country will be processed in the digital and cashless manner. So we are making that digital public infrastructure. And the last bit which I want to touch upon, and which would be relevant for everybody here, that in order to transact in any digital health ecosystem, you have to have a trusted identity and a unique identity in a digital realm. And that's where we are making the registries, which would touch upon citizens, doctors, and facility. So these are named as ABHA, Ayushman Bharat Health Account, which every citizen would have. So far, we have 56 crore ABHAs. That is 1 in 3 Indians have a health account, the digital health account. Second is the healthcare professional registry, where all the medical as well as frontline workers, as well as nurses. Everybody is registered in that HPR. So far, we have created around 2.5 lakh healthcare professional registry IDs. And the last is the HFR ID, the healthcare facility identity, where we want to pinpoint each and every facility in a digital manner so that next time you visit a facility, the marker is there that, okay, you have visited a facility which is not a ghost facility, identified in a digital manner, the record is generated at that place. So this is in a very nutshell, I've given you what has happened so far and what is happening now. And the last bit which I want to give you a figure is, so far we have linked around 34 crore health records to individual citizens. So the India is making leap forward in creation of national digital health ecosystem, where I think all the participants from citizens, doctors, facility, health tech companies, hospital, labs, pharmacy, everybody is taking part to make this dream possible. Thank you.
Thank you so much, Mr. Himanshu, for such detailed overview and information. My next question is to Mr. Sundar. Sir, with increased utilization of telehealth consultations, which government of Karnataka is doing fabulously, what measures have been taken to address the potential barriers to access, and especially in remote and underserved areas? How are you working about it?
Thank you for giving me this opportunity to articulate. Good morning, everybody. I represent the government of Andhra Pradesh. I just heard from our Honorable Minister the wonderful initiatives undertaken by the government of Karnataka. But in Andhra Pradesh, too, we have done similar such initiatives. But the story and the ground realities there take a different form, which I thought I will share in the next 2 to 3 minutes. As I speak here, we have something like around 4,300 habitations that forget about smartphones. We just don't even have basic internet facilities. I'm talking about the far-flung areas in Visakhapatnam, Srikakulam, ASR district, and other places in our state, which is in the northeastern portion of our state abutting Orissa. And the first challenge which we in the health department faced was while uploading the information, creation of the basic electronic records for the people in a village. If we talk about that question, the question is, how do you go to a village, collect everything in electronic form and upload it into an application? And for that, we started building an application. This was some years ago. And the immediate challenge was no internet connectivity in something like 4,000 odd habitations. So what do we do for that? And when we started the idea of rolling out bids, the nearer and the easier locations were taken by private service providers, and something like 3K locations were left for the government to handle. Now here economists kick in. For a few habitations which have just 20 or 30 people, the geographical spread is something like 5 square kilometers, not in plain roads like this, but in inhospitable terrains. And that too, it is in forest areas where getting forest permission was a problem. And then to lay the tower, you require the materials to go, and the electricity board has to come in to lay the basic electricity connection. And the electricity board of our state demanded something like 3 lakhs per connection. Now, where do we go for the funding? So all this, one by one, we started tackling. It involved a Herculean task for the IT department, because we had to interface with the telecommunications department at the center. We had to interface with the private service providers. And then finally, after 2 to 3 years and with a lot of funding support from the government of India, we were able to erect telecom towers and have 2G, 3G, and in certain locations, even 4G connections. The next problem was, for a service provider from the medical, when we wanted to, he comes with a, or she comes with a telephone connection of Airtel or Jio, but the service provider there in the remote location was BSN. Now there was a mismatch. Again, this problem took another 3 to 4 months for us to sort it out. Finally, when everything was there, we finally devised the app, gave it to the Anganwadi workers who had to go there, question each patient, enter it into the record, and upload it to the app. And then comes the national infrastructure mission, which Himanshu was talking about. So unless these ground realities are taken care of, handled very well, and I'm quite sure even Karnataka also has a similar story. Every state has a similar story, and we were one of the states who, metrics-wise, we are at the top. And Andhra Pradesh, we still have to face so much of problems. As I'm sitting and sharing things with you, it doesn't mean that all the 4,000 locations are, the data is uploaded. No, something 60%, we have some more way to go, but we are on the right track because we know what is the problem, we know where are the solutions, and we have been coordinating with the ministries to get the problems tackled one by one. Thank you.
Thank you so much, sir. Do we have a follow-up question from your end, or can we go forward to the next one? Okay. So my next question is to Mr. Himanshu. Sir, so as you shared of the different, the brief overview and the journey of digital health in government initiatives in India, I am sure there are a lot of concerns around data privacy and data breaches that you must be facing day in and day out. So could you please share some insights into the implementation of ABDM in healthcare data management and its effectiveness in mitigating these data breaches and ensuring patient privacy?
Thank you, Asawari, for that wonderful question, because that is what I believe the most common concern which we hear at the National Health Authority, that government is trying to bring all the data at a central server, government will have access to the data of individuals, and so on and so forth. The list goes on. So one thing which I want to clarify to this august audience is that at the National Health Authority, under the ABDM, we have made the architecture in a way which is federated in nature. By federated health architecture, I mean the data stays where it is generated. So in the overall construct of things, data stays at the source. So this is what is happening in the real life as well. Let's say you visit an AIMS, you take a consultation, your data, one copy is given to you, one copy stays at the AIMS. That is the same thing which we are replicating in the digital health mission by alluding to the federated health architecture. Now, the second point, with respect to the privacy. The data from one hospital to another hospital only moves with an express consent of the citizen. That consent can be given through your personal health record application, which would be ABDM enabled. And there are a couple of these applications right now in the market. So only with those applications, the terminology which we use is the health information user has to raise a consent to the citizen that I want to see your A, B, C, D past records. The data where it is stored, it asks for your consent from the patient that hospital B is asking for your record. Should I share? When you give, I want to share only A, B and D, not C record. It is granularity of consent at that level which has been kept into design state so that the privacy of citizen is paramount. This is also in consonance with the latest DPDP Act, where all the data, the digital data, is accounted with the consent of the citizen. So this is a thing which would be in force whenever the DPDP rules come out. All the health tech providers, all the hospitals will have to maintain the consent list that where have the citizens' data being shared. So that is already been kept in design stage at the ABDM. So you can say ABDM is one of the foremost shining examples of implementation of DPDP. So because while DPDP was under consideration in the earlier Sri Krishna committee in 2019 and so on and so forth, at that point in time, we made these points into consideration of design of ABDM. So the privacy aspect is taken care in that aspect, in that light. With respect to security, what we enforce upon all our integrators. Whenever an integrator come to our digital health sandbox, we enforce a minimum level of security testing. So whenever a health tech company or HMIS exits our sandbox, we enforce a minimum security testing done by a certain impaneled agency. So the profound implication which many do not realize, that it is subjecting all the health tech players to a basic minimum level of security check, which they may or may not have at present in the country. We usually hear that the health tech company allude to having a HIPAA compliant or something like in the US, but nothing in the Indian context. But ABDM will enforce that minimum standard of security done by a certain impaneled agency. So that is Indian law, abiding by an Indian agency, tested by an Indian security firm. So these things are taken care with respect to the security. Now, the last part, I'm not saying that that makes the system foolproof. In digital systems, nothing is foolproof. What we are trying to do is mitigate the risk. So because there is no central server, there are different nodes which are integrating. Let's assume the worst case scenario. Even if one node gets hacked because of poor compliance by that particular hospital, by that software, so then only that part is infected. Rest, everything stays intact. So the impact of one node getting hacked or getting exposed does not impact the other systems. And that's where we want to bring the security aspect and mitigate the cybersecurity risk to the minimum. So these are a couple of points which we are doing under ABDM.
Thank you so much, sir. And just to inform our audience, if there are any questions from the audience side, we would be able to take them at the end of the session. Before that, I will move on to the next question for Mr. B. Sundar. Sir, what are your thoughts on the fast emerging technologies like AI and ML, specifically when we are talking about healthcare sector? And can you highlight some specific AI applications that have shown the most promise in your work in Andhra Pradesh?
Thank you. I will approach this question from two different issues. First, the starting point for when we sat about thinking about conceiving solutions for IT solutions for the healthcare department, the starting point was the collection of data. First of all, what do we mean by e-health? That was the starting point. Using of computers, electronics, telecommunication technologies for healthcare services. This was the definition. And I was surprised that there were something like 51 definitions for e-health. So among scholars too, there is no consistency among definition. We took this as a working definition and started with collecting the data. At the turn of the century, 1900, the life expectancy for one person born today on that particular date was something like 25 or 26 years. Coming now, the life expectancy is something like 73.2 years. So the life expectancy increased, but the causes for death was also very surprising. 200 years, 300 years back, a person, if he dies, it is due to scorpion bite, snake bite, death due to while being born, and things like that. But now, causes of death, the scholars are unanimous. At least 60% is due to lifestyle diseases like diabetes, BP, and the complications that are arising from it. So this was a starting point. We collected all this information. And from the government perspective, what can be done to improve e-health? There were several strands to e-health. One was the prescription and the examination in person by the doctor. This was too sensitive for IT devices to handle. So we left it at that. But there were a lot of ancillary services in e-health where IT can play a part. So we didn't think so much about AI and ML when we started. We started with basic technologies. One was for the poor person who is earning 200 per day at the village. It will be a Herculean task to come to one specialist center, forego all this daily earnings and come for a medical checkup. 1,000-fold more painful for disabled. So we spent disproportionately huge resources from the government to address the disability. The disabled persons, we had something like electronic kiosks all over the state, something like 13,000 to 4,000, 14,000. So at each kiosk center, we had the schedule for the next fortnight of all the specialists at the district hospital on the electronic board. That is, a disabled person can come to the nearest Meseva electronic kiosk, look at his disability, suppose if it is spinal cord injury, leg injury, hand injury, or something to do with eyes. The Meseva center operator was trained to tell which are the doctor services that are available on what dates. So electronically, they can book, have the slot confirmed for that particular day, and the disability certificate issued. On that hinges all the benefits for the disabled person. So the next task was to get all the 110, 120 specialists on the digital side. We use very basic technologies, nothing fancy about it. Getting the signatures on the digital platform, having a common template statewide for the disability certificate. This took something like 3.5 years in the making using .NET technologies. But I am proud to say that we were one of the first states to achieve it. So for the disabled persons, it was a relatively more comfortable to travel to the Meseva center, get a slot booked, and have the disability certificate on the first go. But here there was a catch. Sometimes what happens, for the disabled person to fully utilize the benefits, the disability percentage has to be something like 60% or 70%. We made a provision for electronic appeal too. So why I am going into such details is how the state understood the issue and took extraordinary efforts and disproportionate resources for addressing that particular population. So that is where the state comes in. And next, we thought about several other applications where AI could be potentially used. For example, prediction. Okay? Machine learning hinges a lot on prediction. Artificial intelligence is nothing but natural language processing. You give a ton of words to it. It uses the past examples and tries to predict it. Still, things are in the making. We also thought of blockchain, okay? A complete set of publicly available records where the previous record cannot be tampered or altered without everybody knowing it. But this too is in the making. And the application which I was speaking to you about, it is called Sadaram, which won several awards for the groundbreaking results it did. And we also have a medtech company in Visakhapatnam where a lot of IoT devices are being manufactured. And another area where we as policymakers thought would make an impact was in the wearables section. Okay? You wear something, it tells you the heart rate, it tells you the pulse, it tells you how much calories you are burning. But I think we are just touching the fringes here. You go back to 200, 300 years ago, our ancestors spent on average 45 hours, 0.5 something, under the sun, 10 hours per week in the water, and had 9 hours of sleep on average per day. And when I speak the life expectancy is 40, it doesn't mean the person dies at 40. Statistically speaking, more death occurs at the age of 25 or more death occurs at the age of 55. So the life expectancy is at 40. So that is how statistically we talk things about like this. So the question is still out there for all of us to think. How many hours do we really spend in the sun? How many hours do we really spend in the water for us to get that full health? And I live with a concluding sentence. For the health department, okay, if all of us are healthy, kicking around, the hospitals on all the corporate setups that follow have very little roads. It is unlike if several other departments like the IT or roads or whatever, where the more is the better. For the health department, less is the better. So with these thoughts, I just rest my case. Thank you.
Thank you so much, sir. So we also had the key takeaway message along with that question from your end. The same question to Mr. Himanshu. So what would be your key takeaway message for the audience before we move on to any audience questions that we have?
my key takeaway would be that digital is here to stay. So there is no point in fighting it. We have to embrace it.
Thank you so much. Do we have any questions from the audience end? Yes. Can we have a mic for him, please?
Yeah, thanks very much for a very
Yes.
insightful presentation. Although we like to have digital health, we are discussing groundbreaking government digital initiatives. We don't see much of it. I'm sorry to say, it's dismally low. I have a couple of startups working on this digital health, and I agree with most of the problems which he mentioned. The challenges for these startups to translate or transform into digital health in most of the hospitals. We are not discussing the robotic surgery or the use of AI and IoT for digital twins, and then operating somebody in US using the images available in Bangalore for a patient. So, what is the government doing for helping these startups to transform some of the hospitals, local hospitals, to adopt digital health techniques? This is my basic question. But I find it's very difficult for some of the startups to even enter into such areas, like, for example, a village. First, we see the language barrier. We will not be able to even communicate with the patients there. Number two is the availability of the infrastructure, electricity, for example, internet, even to transmit some of the images. So, leave alone the AI, use of AI or ML or the IoT. IoT is the ultimate use. We are nowhere even in encouraging the startups for such a eventful transformation. So I want you to address the help which government gives for this. Funding, of course, is almost nil. We go to banks, our startup reach the banks, our startup reach the VCs, and we get a number of series of questions which we will not be able to answer. So how do you support this to sort of take a leap into digital health? Thank you.
Yes, sir. If you can please take.
That's a very relevant question, and I will upfront I have to tell you that we are just halfway through it. At least I can speak from the government of Andhra Pradesh perspective. We have a society called the Andhra Pradesh Innovation Society under the ITC department, which specifically is tasked with supporting startups and helping them with a mentoring hand. It was established in 2015, and over a period of 10 to 11 years, it has helped to incubate something like 70 odd startups, but unfortunately, not very much in the health space. So they have a screening mechanism. The AP Innovation Society and the Ministry of Electronics and IT, together with the help of NASSCOM, they have established a Center of Excellence in Visakhapatnam. We have a website. You can also visit it. And the Center of Excellence, which is housed in the Andhra University, Visakhapatnam, it specifically focuses on IoT. It specifically focuses on artificial intelligence for the startups. Meaning, if the startups has a good solution based on IoT and certain components of artificial intelligence, then the Center of Excellence will help the startup with a lot of not only funding help, but also other kinds of help like mentor, knit up through networking through angel investors, helping the startups to go through the statutory procedures for setting up a startup company, and so on and so forth. And promising startups also get good funding. For example, here was one startup which helped the defense sector and the forest department in identifying a bunch of animals if they are somewhere patrolling in the forest. So this last year it was awarded with something like 44 lakhs for developing a GIS solution. So this did not come under the rubric of Internet of Things, nor did it come under artificial intelligence, but it simply took location intelligence. And if you are standing here, every person, every point has a lat, long, and a elevation. It's a 3D data. They took this data and they formulated an algorithm which says within this space it is a cluster, without this it is not a cluster. So this kind of classification algorithm they worked upon, and based on sensors they were able to track people and animals movement and tell if there is a cluster or not. So this was the basic solution for which the startup was awarded something like 44 lakhs, which was unheard of in the past 10 years of our existence. So there are similar success stories of other startups also getting help. And the startups, unfortunately, in Andhra Pradesh Innovation Society give a lot of prominence for
What we have started the digital health incentive scheme, under which we give 5 rupees per health record generated by a health tech company. And I'm actually glad to say that so far in the last 1 year we have actually released incentives worth more than 15 crores to the health facilities as well as the health startups. Now, you can say it is not an upfront help, but what we are doing is an outcome-based help which we are giving to them. So you generate the health record, you receive the money. And that's how you can scale up. The second part with you asked about going to the remote places and giving the help in the tech spaces for those facilities. For that, we have launched another scheme, microsites, which Karnataka recently inaugurated. Andhra is going to inaugurate soon. In microsite, what we are doing is we are identifying a geographical cluster where the small clinics, laboratories, pharmacies, all these facilities are encouraged to get onto the digital health platform. And with the help of the state government, interface agencies, and the implementing knowledge partners, these facility, whenever they generate the health record, they will get 20 rupees per health record generated by these facility and 5 rupees additional to the startups which will help them. And these initiatives are helping both the doctors as well as the health tech companies to get on board to the digital health ecosystem. And additional point which I want to highlight is the third thing which we have done, which I think I missed earlier, the scan and share initiative, in which Andhra is leader and Karnataka is at right now third place. They have recently replaced Karnataka. Scan and share is a wonderful initiative at the public health facilities. You can see in Bangalore itself, the KC General Hospital or the hospital in Jayanagar, they have placed a QR code in the public health facility where a common person can go, use their mobile phone, scan the QR code. They don't have to stand in queue. It is saving the time of the facility, of the patients, up to 30 minutes. Now consider the saving of an individual, that 30 minutes, instead of standing in the queue, they are giving it for the patient care. Now, the point I brought this in is because this is all done by the startups. The PHR, the personal health record applications, case in point, the Dreef case is there, Eka Care is there. These are all housed in Bengaluru itself. So they are helping the state governments doing this help and the efficiency level at the patient level as well as the hospital level, and they're getting paid for it.
So my name is Dharam Shukla. So I'm business head at Quad One. So I just heard that you were talking about e-claim. So e-claim. So we are working on e-claim. So I just wanted to know what is current stage of that, because I have seen in most of the hospital. So every insurance have different claim form. Every patient is filling manually. So it's very bad to see that, because I've been in UAE and US, and there everything is paperless. So there is no separate insurance side. So government is taking care in UAE especially, like it's a centralized system. So we don't need to speak to insurance companies. So directly through that channel, we can directly speak to insurance company. So I just wanted to know, like, what is the current plan? Whether we are following UAE or US or something.
Right. It's a wonderful question. What India is doing its own way, I would say. Yeah. We have a robust insurance market driven by both public and private sector companies. I would like to make a distinction between two things. One is the cashless mode of claims, which India is still doing. You can say around 63% of claims are being done in a cashless manner as per IIDI. But the other thing which you alluded to is a bigger problem, is about the, let's say, 36 different portals being managed by a hospital to file a claim, right? And that's where the initial remark which I made about the interoperability in claims. This is what the National Health Authority with IIDI is doing, the National Health Claims Exchange. With that, all the hospital will have to have only one, you can say, entry form. The hospital will upload a form. The best part would be if hospital uses an HMIS, then they don't even need to upload the form. The HMIS will straight away put the claim to the NHCX. NHCX will sort itself out and send those claims to the respective insurance companies. All the insurance companies, in terms of status, I'm happy to say that all the insurance companies are working with us. They have integrated with us in the sandbox stage. Very soon, they will go live. Probably maybe in 15-20 days, depending upon the timelines which we get from the higher officials. But it is in the advanced stages. Soon you will see that at least one product or per insurance company will see this thing in going. But maybe in 1 year, all the insurance products will go through the National Health Claims Exchange in cashless, in digital manner, without a manual intervention, straight away to the insurance companies. And let's say if insurance companies use the AIML, which are also alluded to, then maybe you can see auto adjudication in claims. So instead of having 30 or 40 days of that, you will have a 10-minute start.
Sorry for interrupting. Sorry for interrupting. Can we take the next round, a few questions off the stage, please?
What about the documents of the patient, like ID card, those things, those the insurance companies are asking. So those things also we can automate.
So that's where ABHA will kick in.
Okay.
You go into hospital, you give your ABHA number,
Okay.
right? All the health records are linked to your ABHA number. The same ABHA number is quoted while your insurance claim is being raised. All the health insurance companies are integrating with this ABHA number. So they will know that this patient is coming over there. And soon you will see all the policies will also have an ABHA number. So this is a reality now.
So we will see in reality in few.
This is reality. So in our dashboard also you can see, for example, Aditya Birla Health Insurance Company has created around 28,000 ABHA. So they are creating those ABHA number, and instead of asking for your Aadhaar or any other document, they will ask for your ABHA and they will link that policy document to it. And soon enough, your policy will become a smart policy. So it will be machine readable policy, and that's where the auto adjudication will kick in.
Okay, thank you.
Thank you so much.